The prognosis for everybody with GSD was very, very poor. And the families got together more for support than anything else. Now, one thing I'd like to do is have anybody who has GSD and is over 30 years of age, can you stand up for me? What you can see is there are now many people who are getting older, and when all these people were born, this was considered a fatal disease. You can sit down. But I just want you to see we've come a long way, and we would never have been here if it wasn't for the AGSD. So I just really think this is absolutely critical organization, and it's really because of the organization that all these people, and all of you in this room have benefited. Personally, I got into this field because of the AGSD. 14 years ago, I was invited to speak at the conference, and I was shocked. I was taking care of two families in Boston, and I went to the meeting, and I had lunch with the mother of these boys. These boys were 14 months at that time. They were on the liver transplant list at their local institution, and there was no hope. And my son was 13 months of age then. I just remember sitting there thinking how depressing this was. These kids were on the liver transplant list, and there wasn't a lot of research going on on what was going to happen. And something snapped because of the mother of these boys. And I went back to Boston and decided that somebody really had to care, and I've devoted myself to this disease ever since. And I'm happy to say they never got their liver transplant. They may be 1 month older than my son, but they're 6 inches taller. This was from a year ago. They're now about 6 feet tall, and they're still growing. So it's just wonderful to see really how far things have come. Well, since that meeting, there's been a lot of progress. There are now clinically approved blood tests and saliva tests to diagnose all types of GSD. So we don't need liver biopsy anymore. We understand the cause of kidney stones, and we can prevent them. There's research on the cause of anemia, and that is a complication that should not occur anymore. We now, as we'll talk about on the next couple slides, we understand ways to prevent the adenomas from forming. It used to be something that occurred in 70% of people. We just don't expect it anymore. And new therapies have been introduced, and I know you heard about some of them yesterday. There's been a lot of progress. Another big change is that there were almost no children born at that point when I first came to the meeting. And now, first in our own program, we have had 39 children born to mothers in our program. And that's not even including the fathers. I don't even keep track. We have one mother with 1A who's had 5 kids. We have 2 mothers with GSD1B, 2 separate mothers that have had 3 kids each. We have a mother with type 3A that's had 3 kids, and a mother with type 9 that's had 3 kids. And what that tells me is that people are doing well. Because personally, I don't know how anybody can manage 5 kids at home. And I know I don't have the energy to do that. If you're doing well enough that you can have 5 kids and hold a job, it really shows how far we've come. People have no limitations anymore. I've shown this slide. First of all, you would never know any of these kids have GSD. I'm sorry, the angle doesn't allow me to really use you can see. So we have 1A here, we have 0, we have type 3 here, just to show that different types of type 6. With all the different types of GSD, there are no limitations. People should be able to do anything. And that's my expectation of what this is. I showed this last year. I'm not going to torture everybody. This is from the World Championships in baseball. One of the GSD1A patients played in the World Championships last year, was a starting catcher for the Israeli team. And led the team in batting all year, led the team in batting during the World Championships. That's what I expect GSD should be. Another one of the patients this year was named the player of the league on one of the national lacrosse websites after he scored the winning goal with 10 seconds to go in the playoffs for his lacrosse team. I tried to show, there was a video on YouTube about it, but I'm not computer savvy enough to get that video to show. But that's what GSD is all about. That's, by the way, the GSD patient. When I've shown this before, a lot of people thought it was this fat. But of course, he's just a coach, the short fat guy. So I was given the task to talk about research that's happened over the last year. So I'm going to briefly talk about advances in treatment. I'm going to talk about prevention of complications. I'll talk a little bit about improving knowledge that we have, and then future endeavors. I'm going to have Thomas Collum, the gene therapist from the University of Florida, come up. That way you can also hear someone else talk about it, because I know people, when we talk about gene therapy over the years. So I know yesterday there was a talk about glyphosate. Why do we need new treatments? Well, in our experience, no child and less than 10% of adults with GSD1A sleep through the night and maintain adequate control. I'm a perfectionist. I expect all that to be normal. And while people could survive going through the night, some people, they weren't achieving the level of control that I expected. And so people were just waking up at night and that leads to problems. Even with types 3, 6, 9, many people had to stay up later than, parents had to stay up later than they would intend to just to get before church didn't say at midnight. And so it's impacting on quality of life. It impacts on the risk that goes along with treatment because people invariably oversleep or they hit the snooze button. So we needed new treatments to come along. We had a whole talk on this yesterday, so I wasn't here, so I don't know what was discussed. I just thought I would summarize with one slide because I think this is a huge advancement. Glyphosate was approved as a medical food and is released as a medical food in January and is now on the market as of last week. We have, Kathy, I think it's about 40 people on it right now, and we've been testing it in people coming in since January, and the response has been remarkable. Almost everybody now is sleeping 8 to 10 hours through the night in the older population. There are some caveats. It's not perfect in the younger people. It's only approved for people 5 years and older. But it offers hope for sleep for a lot of people. And it's already made a huge difference. One of the parents called me and said after starting it at home and going on it, that it's like being on a drug. She doesn't need drugs or anything because sleep, she now has sleep, and that's better than anything that she could ever take. And how wonderful and how life-changing it was. Since you had a whole talk, I'm not going to really talk about it. If there are questions, one of the key things is what we found is that when we started, we were underdosing it. And in order to get the 18 hours, most people needed 135 grams at bedtime. So it's a big dose, but for the range of about 120 to 150 for the adults and a little bit lower for the younger population. There's been tremendous advances over the years, even in the last year, on preventing complications. There is increasing evidence that complications can be prevented or completely avoided in all types of GSD. We've really made a lot of progress in this area. So with regards to hepatic adenomas, again, I'll show you some data on this. In my mind, hepatic adenomas now are preventable. We know that metabolic control is important. It's not 100%, but it used to be 70% of people got adenomas. It's now, it's the minority of people who develop adenomas. And my expectation is that with food control, we're really going to prevent that. And that's true for 1A and 1B. Dr. Minarich, she's somewhere around here, I think. Dr. Minarich published an article on osteoporosis and showing that normal bone density should be occurring. We give people calcium, we give people vitamin D and have good control. People with GSD 1A and 1B, and Chris Peterson from the Netherlands has published, presented data that's being published right now, showing that osteoporosis can be prevented in type 3. Anemia, David Wayne, who's now in Seattle, has published an article on anemia and the cause of anemia. The splenic complications that used to occur in 1B, we realized are very much related to the GCSF. And when low-dose GCSF treatments used, nobody gets severe complications. They get a little splenic compartment, but the problems disappear. There have been 3 reports that have come out, 2 in the last year, that show that cardiomyopathy in type 3 can be completely reversed. The French group, the Netherlands group that we had published one also, showing that the heart disease is preventable in type 3. It's due to overtreatment. And now you have multiple people saying, you're going to hear later, and I'm not going to go into much detail because other people are talking about type 9. Cirrhosis has been reported in a subset of people. But what we can show is that with improved control, good metabolic control, the labs normalize. And when that happens, the spleen shrink up, and the liver heals. And I also convinced, although it's still very preliminary, that cirrhosis can be prevented if we can keep the liver from being inflamed. And finally, my expectation is that all people, 0, 1A, 1B, 3, 6, 9, will have normal growth when they have good metabolic control. But it all comes down to maintaining good metabolic control, not accepting abnormal as normal. Push for normal abs. Well, this is what I was alluding to earlier with the adenomas. We had the meeting a couple of years ago, which you heard about from 1A, that said that the consensus found that 500 was what the consensus panel decided was adequate control for 1A. Not good, but adequate. And so we've analyzed what happens when people have triglycerides above 500 versus below 500. And what this is people who don't have adenomas, and once going down means you develop an adenoma. And what you can see is with poor control, there's a much higher rate of developing adenomas than if you have even fair control. But we analyze this, if people maintain an average triglyceride of under 300, nobody developed adenomas. So in my mind, that we should not be seeing it. And we're seeing many adults now who do not have that, even though at one point we said it was basically an average. If you look at people who develop adenomas, their mean triglycerides when they develop it is 737. If you take age match, gender match, people, so that who don't have it, with GSD they have lower triglycerides. That's just another way of looking at it. So the key thing is push for good control. So what happens if people get adenomas? You can just follow them, which is, the problem with that is that there's always the fear of cancer, although I think the risk is low. There's a risk of bleeding into it, and just the anxiety that you can cut them out with resection, and we've done that 14 times when we've had to do it, and every case has gone well. But it requires experience, because the surgery is tricky, and you need people comfortable dealing with the GSD in the operating room, because when you're doing liver surgery, it's not easy. You can burn them out or freeze them out with what we call ablation. And then there's transplantation. The next couple slides are new data that came out just in the last 3 months on transplantation. But I just want to say that following up on the metabolic control, what I was just talking about, we have 11 people in our program who came to me with MRI-proven adenomas multiple times, lesions as large as 5 centimeters. And when they got on good control, when their triglycerides normalized and their lactates normalized, the adenomas have disappeared serially on MRIs. And so there are people in this audience, and people don't believe it, there are people in this audience that it's happened to, where it's disappeared on serial MRI scans. So let's talk about liver transplantation, because I personally think that nobody should need a liver transplant anymore, except for GSD4, which is a little bit different disease. Liver transplants, in my mind, are a treatment of last resort. And the prognosis for everybody with GSD is so much better with medical care and with good metabolic control. So this article just came out in the May-June issue of Clinical Transplantation. It was published by a group from the Washington, D.C., Baltimore, Maryland, the Maryland area. And they went through the National Registry for Liver Transplants and pulled all the cases of GSD1. And what they did is they looked at the survival. This is just basically anybody who has a liver transplant goes in the registry. They wanted to see how the type 1As were doing. And what you can see is that after 1 year, 82% of people were alive. After 10 years, 64%. And that is better than in the non-GSD population. So there are 2 ways you can look at it. You can say that's wonderful. If you need a transplant, the chances of survival are much better than in the non-GSD population. But the way I look at it is that's not good enough. I don't want to take a chance, a 1 in 5 chance that I'm going to send someone for a transplant that they're not going to make it within the first year. And even at 10 years, you can say 64% is great, but that also means that over a third of people are not going to make it. So it's not a treatment we should be striving for. It's a treatment of last resort. And we only do it We haven't done one in many years because we haven't needed to. With good control, you shouldn't need it. But these are the non-biased data from the recent report. If you look at what happens to people who've gotten liver transplants, this article was put out by Dr. Kishnani and the group at Duke, who've had tremendous success with their liver transplants. But one of the things that even if people survive, a lot of the people progress to renal failure. So what you can see here is in 3 of the 5, this is from their article, 3 of the 5 patients who had the transplant had progressive renal dysfunction. There was another article put out by Mike Davis who analyzed this, and long-term almost everybody progressed to renal failure and a lot of people needed dialysis. So again, this is not a cure. Transplants are treatment of last resort. It should not be viewed as, let's just do this because it's an easy fix. What about 1B? So there's a new article that just came out on liver transplant in 1B. And what you can see is I summarized there that there's a very high rate of infectious complications in 1Bs who have liver transplants. The neutropenia persists, inflammatory bowel disease persists, and there are a lot of complications from it. So again, we shouldn't be just rushing to transplant, only use it as a treatment of last resort. This was just from that aforementioned article from Mike Davis, which he talked about renal failure in 1As, 1Bs that persisted neutropenia and IBD. And in type 3, a lot of the people think that liver transplant is curative, but what they found is that following liver transplant, there was worsening cardiomyopathy and the muscle disease is not treated. So again, but the whole reason I'm showing this is, first of all, I was asked to review the literature. These are all new articles, but also I want people to realize, strive for perfect metabolic control. Well, how can you get it? But there's a new article put out by Fiona White from England and the team over there that talks about use of the continuous glucose monitor. This was in the journal Inherited Metabolic Disease. And what they did is they put people on the continuous glucose monitor to try to figure out where sugars were dropping. And this is one of their diagrams. And what you can see is that these were people who they couldn't figure out what was going on. And when they put them on the continuous glucose monitor, they picked up some low sugars that hadn't been picked up just through routine finger monitoring. At least they could adjust the treatment. Now, there were some caveats with this. First, this is not meant to replace monitoring. It's a useful tool if you can't find why people aren't doing well. In my mind, still the standard of care is bringing people in, doing the hourly monitoring so you get more precise data, it's more accurate. But this supplements the home glucose monitoring, the hospital monitoring when you can't get perfect control. It's useful for discovering patterns, but it's not real good at absolute value. So there are many people where the sugar would be reading 70, they were actually 50 in the lab. So it wasn't perfect, but if you saw the downward trend, it was useful. So you would know that the sugars were dropping there. So it's useful for patterns. The authors point out that 20% of the hypoglycemia is missed with the continuous glucose monitor. So it's not perfect, it's a trend, it's a tool. And then the accuracy falls as people got hypoglycemic. So that's a problem for this. But it's another tool that we can use to help make sure that people get optimal control. There's going to be a talk on type 3, so I'm going to limit my comments on the other types. Just to make sure people know, the international study for GSD3 is an international collaboration. The results from that collaboration are being slowly released. They started coming out, and they're going to be released over the next year. There are over 300 people in the database there, and it's going to really give us good information about which treatments are working, the natural history, and how to really move forward with type 3. There's a new Faroe Islands Type 3 Research Institute. For people who don't know, the Faroe Islands, I didn't know where this was. The Faroe Islands are halfway between Iceland and Norway, and they have the highest rate of GSD in the world. 1 in 22 people on the islands is a carrier for type 3. Lots of GSD there. And because it's so prevalent, it's a great place to study type 3. So we're going to be using this
as a way to study new treatments. It's a joint collaboration. We're doing it with doctors from the Faroe Islands. We're doing it with a doctor from Germany, and also with Peter Smith's group from the Netherlands. So it's a great, I think, I'm very excited by this. And by the way, this research program was supported by a Major League Baseball player. And Johnny Damon, I don't know if people know who Johnny Damon is. He has no connection to GSD or GSD3, but to get a Major League Baseball player to invest in GSD is really amazing. And I'm very excited by the potential for doing research on type 3. And also a huge advancement for the type 3 you're going to hear about coming up in the type 3 talk is really characterization of the type 3 dogs at Duke, and you're going to hear about it. I think this is an absolutely critical tool. Tom's about to talk about gene therapy, and we made advances with the gene therapy and the type 1As, and Stu's done work with the 1Bs with gene therapy. For these dogs, it's going to be critical for gene therapy to type 3. And so I'm not going to talk any more about it because we're going to have a whole talk on that, okay? And now that leads us to gene therapy. What I want you to get out of what I've said is that my expectation is that people with GSD should do absolutely great. Strive for good control, and with that, people are going to stay healthy. But our ultimate goal is to cure it, and that's where I think most of the investigators are going. What I put here is the recent articles from Dwight and the group at Duke and our team. A lot of progress has happened with the gene therapy in GSD1A, and I'm going to hand off to Tom, but I just want to recognize that this is not an individual effort. This is a huge undertaking at both Duke and here to do gene therapy. So at the University of Florida, these are some of the key members. Thomas is going to talk now. Absolutely amazing gene therapist, and we're lucky because we have a great gene therapy team. Travis, who is back there, and Lori, they're up most nights in the middle of the night as the dogs have medical issues or things have to be done. They're getting woken up every night, and we wouldn't be here if it wasn't for them. We have a great vet team that has allowed the work to be done, and we've had over 80 students over the years rotate through, and this site's not even complete, rotating through caring for these dogs. So it's a huge undertaking. I don't want it to come across as my work or it's Tom's work. It's all of our work. It's the team effort. It's not one or two people. And these are, of course, the most important members of the team. These are all dogs that have GSD1A, and the dogs have had gene therapy. So I'm going to hand off to Thomas and let him talk about gene therapy.